All right, everyone, welcome to the General Thoracic Surgery Database, our user group call. Today is Wednesday, August 23rd. I can't believe we are almost done with August and headed to September. So I hope everyone's having a great week thus far. On the call with me today, let's see here, from the STS side, we have myself, Emily, Conrad, Carol Crone, and we have Ruth Raleigh as for our consultant, our GTSD consultant. In terms of the agenda, I'm just going to provide some brief STS updates, and then I'll turn things over to Ruth really quickly. We don't have too much information to share today. And then, as always, we'll finish up with the Q&A. So if you have any questions, please submit them via the Q&A. And as always, the raise hand function is enabled. So if you want to just raise your hand and answer your question, you're welcome to do so. Just make sure that your microphone is enabled on your end. All right, let's hop into our STS updates. If you were on our last call for our last monthly webinar, much of this information will be repetitive, but for those of you that were not on, I just wanted to touch on this information again rather briefly. The August training manual is posted and the FAQ summary document is available. And of course, that FAQ document does include the updates from May, June, July, and August, and that is available out on the website. I'm sure many of you are well aware that our Fall 23 Harvest close is quickly approaching. The Fall 23 Harvest will include surgery dates of 7/1/2020 through June 30th of 2023. The harvest is scheduled to close on September the 8th. The opt-out deadline is September the 12th. And then new for this harvest, we will have, as I talked about on the last call, the pre-analysis report exclusion warning. So that will be coming here very soon, and I'll jump into that here with this slide. The pre-analysis report exclusion warning, the goal of this supplemental report is just basically to improve data completeness issues and ensure that you all have as many records included in the analysis as possible. There will be an email sent to those participants who are at risk for exclusion approximately 1 to 2 weeks prior to harvest close. I think I'll be sending that a little bit closer to 1 week prior to the harvest close. So again, those emails will come from me. And if you have any questions regarding the email, once you receive the communication, please do not hesitate to reach out to me directly. All my information will be included in that email, in that email. The 2% missing data thresholds are calculated based on the overall composite population eligible for reporting. And of course, if you have questions about those 2% missing data thresholds, that specific information can be found in the analysis overview posted within the IQVIA platform library. And along with that warning email, we will include a participant-specific Excel spreadsheet containing a list of all of your records that meet the reporting eligibility requirements, but are missing one or more of the required fields. So again, this is just another tool available to you to help ensure that you all get as many records included in the analysis as possible, and to help you ensure that you're meeting those that 2% missing data threshold for those mortality variables. That Excel spreadsheet will include the participant ID, the patient ID for that record, the record ID, the report year, and there will be flags indicating which specific variable are missing for that record. Also coming soon, as mentioned on our last call, STS will be activating 2 of our STS temporary fields. We'll be activating sequence 4580, the temp yes, no field, as well as the sequence 4620, which is a temp text field. Carol and I are working on communications and additional information on exactly when we will be rolling that information, rolling that out. So we will send a formal communication to the participants, your surgeons, as well as the vendors, with more information on when those fields will go live, what exact data we will be collecting. So again, if you are currently using those 2 fields, please stop. Those fields are not to be used for data collection until expressly instructed to do so by the STS. So again, if you are currently using those 2 fields, please stop. Excuse me. Again, an official communication will come to us in the coming weeks on when those two fields will go live and exactly what new data we will be collecting. Next, I'm going to turn things over to Emily for a brief AQO update. Emily?
Hi. Yeah, so our registration is open on the website. We have added an agenda with our topics and our speakers for all of our sessions. So General Thoracic, it'll be on Wednesday, September the 27th. If you are not registered for AQO and you would like to have like a justification letter filled out, a link for that is also on the website. That letter is just a letter that's addressed. You fill in like your supervisor's name, you fill in your name, and then it is a letter that is signed by the STS president, Dr. McGilvery, just kind of outlining reasons why attending AQO is beneficial for you and for your institution. So that is available as well. And just as a reminder, this will be a virtual conference, and we will have both on-demand and live presentations. And then the live presentations will be available for viewing after the meeting has occurred. We'll be offering CE and CEU credits. Information regarding how many credits will be available will be put on the website shortly. And I just want to also mention that we will have like PowerPoint presentations. If there's case scenarios or any handouts, those will be on the website as well. And we'll also have e-posters. So hopefully you'll be able to attend. We'd love to have you there.
Great. Thank you, Emily. And just rather quickly, I just wanted to bring over the website and just show you how to quickly get to that information. So for the education, you can click on calendar of events. This is just how I get there. Scroll down, click on 2023 Advances in Quality and Outcomes, a data managers meeting. And as Emily stated, all the information can be found here. You can register now, the dates, the link to the justification letter, view the agenda, all the information that you need, pricing, everything that you need can be found here. If you have any questions, you can reach out to our meetings and conventions department. If you have any abstract submission or program questions, you can reach out to Emily via this link here. Thank you so much, Emily. I can't believe we're getting closer and it's going to be here before you know it.
Yeah, it'll be next month at the end of the month. Yep. Crazy.
Yeah, we have a great agenda for GTSD, so I'm super excited. Looking forward to AQO this year. We have some new faces presenting this year, which is awesome. So we're really looking forward to it. So hurry up and get registered, and we can't wait to see you guys at AQO this year. And definitely looking forward to seeing you guys in person in 2024. All right, since the harvest close is quickly approaching, I just wanted to quickly go over some of the harvest close checklist, just to refresh your memory if you're new to this. There is a harvest close checklist available to you in the IQVIA platform. It can be found in the library. So just briefly touch on the various reports and tools that are available to you to ensure that your data is complete as complete as possible prior to for the harvest close. So again, we do urge you to utilize those resources available to you. Be sure to review that data quality report for each upload submission. That data quality report will allow you to resolve any critical errors and review errors or warnings and correct those errors and warnings as needed. Also, be sure to review that critical summary report. When you're working with that critical summary report, it's important for you to enter the data file submission date. So when you're filling in your filters here, you'll just want to enter the range of the data files that use the dates on the data files that were submitted. This is not asking for your surgical date range. Once you do this, you can use this critical summary report to review your uploads to verify surgery dates and total number of records that were submitted for each upload. So again, that critical summary report and the data quality report. Also, I encourage you to review the harvest summary report. The harvest summary report is located under your operational reports. This harvest summary report allows you to look at, again, at all the critical errors, your errors and warnings for a specified date range. If you want to clean things up in chunks, you can just clean it up in year by year, month by month. But again, it just allows you to look at all those errors and warnings for a specified date range and clean that up. You can also use this harvest summary report to verify your total number of records that were submitted for a specified date range. And I highlighted here, you can find this information up here. So I would suggest putting in the date range for the analytic period. So I would put in date range of 7/1/2020 through 6/30/2023, and just verify that the total number of records that were submitted match what you're expecting. Another report available to you is the missing variable report. And of course, this too is located under the operational reports tab within the IQVIA platform. And this missing variable report will allow you to pinpoint any records that contain missing data. It's very important to ensure that those mortality variables are complete, your mortality discharge status, mortality 30-day status, as those are the variables used to determine that 2% missingness threshold. It's also important to note that unknown for MT30 stat is considered as missing data in analysis. So again, just utilize those resources available to you. This harvest close checklist goes through each of these reports for you. It's out in the IQVIA library. I encourage you to, for our newer data managers, print that out, have it, just walk through it and just use that checklist to make sure your data is as clean as possible. And also, in addition to these resources, we are again providing that at-risk email and spreadsheet to you just prior to harvest close. Also, I encourage you to review the participant dashboard. Going through the participant dashboard will allow you to confirm your record counts again. You can look at your mortalities, identify any records with any missing or unknown data. For example, status at 30 days after surgery, you can look at your mortalities here. It says you have for this example, there are 5 mortalities. So it's just another way for you to confirm that the data that you've submitted is accurate and the number of mortalities submitted is what you're expecting. So again, just another resource for you to confirm record counts, mortalities, and again, records with missing or unknown data. That's all that I have. Just going to turn things over to Ruth real quick. She's got some brief update to provide. So Ruth.
Thanks, Leanne. So we're going to hop into just a really, really super high level overview of some of the most common audit errors from the 2022 audit as we head into the next harvest. Just a little plug for EQO. I know that Katie and Whitney, I believe, are working together to put a presentation together for EQO to sort of dig deeper into some of these audit errors and these measures. And then I'm going to put together a presentation to really dig into some of these with a bunch of examples for EQO. So I think that'll be a really helpful talk. Another talk that's happening at EQO is looking at the analysis from a data manager's perspective, and Harris, who is a brilliant statistician and a wonderful explainer, will be presenting that talk at AQO. So if you can make it, please make time for it. I think it'll be great. So Leanne, if you want to pull up the training manual, we'll just quickly go through these measures, and I have them all listed out here so you won't have to flip back and forth between slides. Let's go in order, so in sequence order. So we'll do 580, which is re-op. So again, the 2022 audit was completed using the prior version. So I think we did a great job between version changes, sort of cleaning up some of these definitions and hopefully making it a little bit easier. But as you can see, there were lots of questions, even in the new version on sequence 580. The takeaway on this one is that in order for something to be coded as a reoperation or a prior surgical history in the planned operative, or a patient that had a prior surgical history in a planned operative field, is that they have to have had a surgery in the same anatomic space and the current procedure has to have been made more challenging because of that prior surgery. So really that July 2022 update is critical. And then I think if you scroll down just a titch, there is a diagram that defines what the anatomic spaces are. And again, it's the sort of subsets of the anatomic spaces, not the whole space. So for example, the thoracic cavity is divided into multiple subspaces, and we're talking about patients that have had more than one surgery in the same subspace that also had a more complex current operation. So documented lysis of adhesions is the example that we most often give. And if you have questions on any of these most frequently missed variables, please put them in the Q&A or raise your hand and unmute, and I'm happy to talk through any of them as we go through this. The next sequence is 750 FEV1, and there's a question in the chat on this one, so thank you for setting up this conversation well, Lori. So I think there's a lot of confusion for FEV1. So again, you choose the highest reported value, percent predicted, whether or not a bronchodilator was used. You can calculate both of those using the mathematical equation that is shared there sort of in the middle of the screen where it says PFT report, and there's the math calculation 2.65 divided by 3.80. And we've gone over some examples like this historically in the past, and we're going to go through some more PFT report examples at AQO. But what's really key is that blue underlined text. It says this field is required for record inclusion. If missing data, the entire record will be excluded from analysis. If you scroll up one sequence to 740, it's got the same text. This field is required for record inclusion. If you answer no to 740, meaning your patient didn't have PFTs done, then sequence 750 isn't going to be open, and so you won't have missing data. So the question that was in the Q&A was, where can acceptable exclusion criteria for pre-op PFT testing and lobectomy patients be found? There really isn't a list of acceptable exclusion criteria anymore. If you didn't have PFTs performed, you just say no, and your record will still be included. You're not missing data. The only way that you're missing data is if you completely leave your answers blank. So just remember to say yes or no on that parent question, and you should be all set for PFTs and then FEV1. And then the other field that will open are your DLCO questions. So if you scroll down to the next couple of sequences, again, you have a parent, sequence 770, which is DLCO test performed. You're going to say yes, no, or not applicable here. If you say yes, then you will enter the value for DLCO. I think DLCO got a little bit more confusing this time because you can use different, I mean, they're equivalent values. They're all reasonable inclusions, but you have to use an uncorrected DLCO value. And in everybody's PFT reports, they look just a little bit different, which is frustrating but true. So you would capture the lowest of DLCO uncorrected or DLCO _ SB or DLCO VA, as long as it's not corrected for hemoglobin. And there's going to be another update in September of 23 coming, another equivalent variable, just a different way that sites are writing the same value, just showing up a different way in PFT reports. So if you have questions about anything on FEV1 or DLCO, feel free to send me your specific PFT reports. Unfortunately, they're all just a little bit unique. Let me see if there's any questions popping up. Okay, the next sequence that had a lot of mismatches was 870, which is ECOG. A big change for ECOG was that it has to be documented in the record. No longer are you allowed to impute a value for ECOG. You can crosswalk things like Zubrod over to ECOG, or Karnofsky performance score can also be used as long as you crosswalk it over. It can't be an ECOG score that's documented after the patient had their surgical procedure, such as by an oncologist. It has to be preoperative. If this data is missing, the record does not get excluded. However, it will impact your risk adjustment because ECOG is part of risk adjustment. So hopefully that's getting put in your notes by clinicians. The next one, sequence 1470, which is procedure. So the audit for this one really looks at whether all procedures are being entered. So if you look at the intent clarification, it says check all the procedures that were performed. So if your patient had something they see sort of frequently is like a hernia repair with a gastric bypass procedure, that happens pretty often. And I think that because the gastric bypasses are often performed not by the thoracic surgeon, but by a general surgeon, data managers will leave out the procedures that were performed by the general surgeons, but truly it's all procedures that were performed within the same case. So if you're doing a lung resection for lung cancer and they call in, I don't know, I mean, truly anything as crazy as like an orthopedic surgeon to like remove a toenail, like that gets put on your list of procedures that get performed. It's everything that happens. But of course, it's very important that your primary procedure is selected based on weight of the procedures, or you'll get a weighting error from IQVIA. The next one, sequence 1800, which is lung cancer tumor size, has been challenging. There's been a lot of updates to this one. So for mixed density lesions, you want to enter the tumor size in centimeters of the solid portion only of the nodular lesion. If a nodule is purely ground glass, you're putting in a 0. If there's mixed density lesions and there's not documentation, you can leave 1800 blank. And then there's a lot of guidelines about, you know, if there's multiple studies within a 3-month period, which one do you pick? And that's all clearly delineated here. So be sure you read through all of these guidelines very, very closely as you clean up your harvest data. Sequence 1880 is the next one. So pathological nodal staging. So again, the audit data was from 241, and there were a lot of changes in this one between the last version and this one. So I'll be curious to see on the next audit. We switch over for the next audit, right, Leanne? It's 521?
Yes.
Yeah. I'll be curious to see how the 521 audits turn out with the changes to the sequence. But there's very specific guidance and updates in here on how to count lymph nodes. In the prior version, it was just like a sum total. And now that we're entering it in station by station, I'm hopeful that we'll see a greater match rate on these 521 audits. But be sure you're following that specific guidance on nodes sampled by EBIS versus nodes harvested during mediastinoscopy, and what to do with patients who have had induction therapy of any kind. The last one with a pretty decent mismatch rate was sequence 3670, which again, we made some big changes to, huge changes to from the prior version, which I think mostly have been very well received. We've gotten a lot of questions from sites about how, you know, what we're going to do about sites who have only submitted 521 data because of the differences between the way that this sequence was in 241 versus 521. And I think, Leanne, you've been managing most of those questions. Mm-hmm. But the intention is to really capture returns to the OR or events that are contributing significantly to morbidity and or mortality. And so, you know, while in the previous version, we were capturing things like chest tubes and chemo ports, and like every single time a patient got poked with a needle, that's not the way that this sequence works anymore. And I think that physicians are very happy with that change. And I know my surgeon's ecstatic and can't wait for the 241 data to fall off for this specific reason. And so that's a quick walkthrough of all those. If there are any questions on any of those, looks like Laura has a question. For all the procedures done in the same OR visit as the case being abstracted, list all the procedures done by a different surgeon, even if they are dictated in a separate op note. Yes. Even if they're dictating separate op notes, if it was the same trip to the OR, you'll capture all the procedures performed.
Excellent. So question, is there an IQVIA report for lung resection and staging volume? Ruth, do you know off the top of your head? I would have to pull up the
For lung resection. Oh, the lung resection one is the one that's not yet completed. I know a lot of people have asked for a lung resection report.
Yep.
And I can't remember where the timeline is at on that, Leanne. I don't.
Right. We've added that to our list. We're working with IQVIA, so I don't know. I don't have an exact timeline of when that would be rolled out. But we are working to, I know the task force and Dr. Cedar had, approved this request, and we are working with IQVIA and the research center to get a lung resection and report for the platform. But unfortunately, I don't have a specific timeline, but it is in the works. We are working to get that report available, Nancy.
30-day follow-up has to be after 30 days or can be prior to 30 days. It has to be after 30 days.
Yeah, it's 30 days from the surgery date. After. All right. Odette has a question.
If the patient procedure was completed and the incision closed, but was reopened before leaving the OR, I believe, I'll look back through my notes, Odette, but I'm fairly certain that the conclusion on this was that you don't capture a postoperative event if it occurs before the patient leaves the OR for the index procedure. If it occurs in PACU, then it's considered post-op and is always counted. But if the patient is still in the OR, I believe, but I'll send you an email, I'll confirm, I'll look back at old notes.
Perfect. All right. Any additional, Odette says, thank you. Our next question, what if my patient had a mediastinal mass removed the same time as a cabbage? Should I list mediastinal mass removal as my primary procedure, include the cab as secondary?
Yep. If you choose to submit mediastinal masses. And I think that reminds me of an important point. I've gotten lots and lots of questions about cases that are only benchmarked and not risk adjusted procedures. So the only types of procedures that are risk adjusted are lung resections for cancer and esophageal resections for esophageal cancer. The other procedures are only benchmarked. And I know that some sites, including my own, use the benchmark data and presentations back to the hospital. And so they want to self-edit, I guess, which procedures get submitted for the benchmarked procedures. But the STS would like all of them submitted. So if you're submitting mediastinal mass, submit all of your mediastinal masses. Obviously, this patient that had a cabbage at the same time has a much higher risk level than the average bear. But the STS wants that case if you're choosing to submit that type of case. You can always, when you're presenting benchmark data back to your hospital, if you want to remove cases that you feel like are outliers, you can do so. It's your data to share. I think you would want to share with your hospital that you've removed complex cases and then, give your examples, but that data, the benchmark data is not risk adjusted in any way, shape, or form.
All right, we got several questions rolling in, Ruth.
A case this week on a patient in which the surgeon took an additional hour due to adhesions. I understand your point on the complexity caused by the cabbage. I can take the question back to the core group and or task force, but the decision that was made was that it has to be in the same anatomical space. And so that's where we have to leave it for now. But fair point.
Would you want that submitted, Ruth, so you can have a record of it to take back, or does she need to do that? He or she?
Yeah, that'd be great.
Okay, perfect.
Sorry, Ruth, is this, this is Carol. The question that we just had about the surgeon took an hour to dehiss the area. Is the field we're talking about, is it the post-op?
No,
field?
it's the re-op field. So
Yeah, so aren't we talking about two different things here? In that question that was just submitted?
I thought they were talking about re-op.
No, it's, oh, I don't know. Hold on one second.
The code first occurrence in plural space. Yeah.
So we had a case this week on a patient in which the surgeon took an additional hour due to adhesions caused by a prior cabbage internal mammary takedown. It doesn't seem accurate to have to code first occurrence in the plural space if patient had a lima harvested.
Right. I
Is
thought
that-
the thing first, like it's the surgeon's first time in the plural space
Oh, yeah.
for the field of re-op.
Oh. Okay, thank you.
Yeah. And part of the rationale for that is there are instances where a patient will have significant adhesions in the pleural space for other reasons, serious infection in the past or radiation in the past or something like that. And you wouldn't code re-op in those cases either. So it's not necessary. Like the intent of re-op is not to capture just additional time, because there are lots of instances in which patients will have adhesions there, and you still have to code no to re-op.
Yeah, no, that's helpful. That's very helpful.
I think that helps give some additional context, I guess.
Yeah, thank you.
Yeah.
For me, it does. Thank you. Sorry to butt in.
No, I appreciate
Because,
it.
we have similar questions in the adult cardiac database.
Yeah.
And we do the same thing. So and I don't want to go off track, but just an example, if the patient had a previous lung and now they're coming in for cabbage, it's in a different anatomical space. So that's the first CV operation if they've never had a heart procedure in the pericardial space before. So I think we're similar.
Yeah.
Thank you.
If a patient is discharged and the 30-day readmission timeframe falls after harvest, should I just leave the readmission spot as unknown? Length of stay was over 100 days.
Patient's discharge. Falls after harvest. Carol, did you want to answer that one?
This is exceptionally rare because of the delay in harvest. It's like your patient's sort of in a little loop between still in the hospital and the delay in harvest. I don't know, Carol. I've never had a case like this.
Are you on mute, Carol? I don't know if you're.
Oh, it's very likely I'm on mute.
I was like, Carol, I thought you
I was
wanted
sitting
to
here
answer
having
it.
a very, very good conversation with
I was
myself.
like, it looks like she wants to answer, but I don't hear her.
Yeah, this is, we can either, I don't think this is a required field, right, for general thoracic. So I would probably leave this as blank until you have the data. Because if it's not gonna hurt you. Are you there? Can you hear
Yep,
me
I'm
now?
here.
What
Thanks,
do you
Carol.
agree? What do you think about that, Ruth? Do you agree?
Yeah, the
yeah, I think-
readmit. Yeah, the readmit to 30 days is not required, a quote, required field for, required variable.
Yeah, so I would, and since it falls after you don't have that information, I would just leave it blank. I think unknown is more, and Ruth, this is our thought in the adult cardiac is we use unknown more for if we looked for the information, but we really couldn't find it versus the information isn't due to be ready yet. Does that make sense?
Yeah, that makes sense.
Okay. You don't have to agree with me, just tell me no, but
No, that makes sense.
tell me it's crazy.
No, blank is an absolutely great entry at sometimes no entry is the best entry.
I would leave it blank, but make sure you go back and fix it.
Yeah.
Yeah.
Make sure you provide that. Don't leave it blank for the next harvest. Fill it in when you get the information.
Okay, next question. Is it acceptable to use the hernia description documented in the surgeon's progress note to determine the hernia type, or must the hernia type be explicitly documented in the medical record? Will this be acceptable for audit purposes? As far as I know, hernia cases are not audited. Feel free to correct me if that's not
You're
true.
correct. Yep, hernia cases are not, it's just lung and esophageal.
So you are free to use the documentation that's in the EMR. However, I will tell you that was my least favorite thing to try to figure out. And so I had my surgeons added in to their op notes in the description of the procedure performed. They now always put the hernia type, because if you can figure it out from the notes, God bless you, it's such a tough one. Next question. A patient had a bowel resection for colon cancer with radiation and chemo. In 2020, during surveillance follow-up this year, the CT showed lung nodules. Pathology came back metastatic cancer from colon. Would I answer same disease greater than 6 months or unrelated disease greater than 6 months? First of all, Joanne, you do not have to enter this case because it's not a lung resection for lung cancer. However, if you choose to enter the case, you would call it the same disease, because it was colon cancer before, and it's colon cancer again. But when you enter your primary category of disease, you'll call this metastatic. It won't be lung cancer, and it'll get bumped out of your analysis and your risk adjustment. It won't be part of your star rating. Joe would like to know when this webinar would be available to view.
I can answer that one, as it is a very non-clinical question. I've got that one. The webinars are typically available within 48 hours. So after this webinar, I'll send the link over to our marketing team, and then they will have to curate it. And so I would say at least 48 hours. If it's not available on Friday, it should be available first of next week.
The next question is clinical. I think this one's mine, Leanne.
That one's all yours, Ruth. It's all yours.
Heather would like to know if robotic assisted lobectomies is it appropriate to code the thoracoscopic? Is it appropriate to code the primary procedure as thoracoscopic, or should the removal of lung single lobe option be used? The removal of lung single lobe option is the open procedure, of course. So you're going to want to use the thoracoscopic procedure, Heather. For anything that's robotic, you're going to use the minimally invasive code. And then there is a sequence, and I don't remember the number offhand, but it's going to ask you to indicate that the robot was used. And then there's also a procedure code for robotic assisted procedures as well. We capture robotic assisted in a couple of other places. So you'll get if your surgeons ever wanted to know which ones were robotic versus which ones were just straight up thoracoscopic, it's pretty easy to go back and look at that data. I'll answer Maggie's question. How would I treat a cavitary lesion for determining lesion size? Is it considered solid, part solid, or non-solid? Cavitary lesions are considered solid. The middle is just sort of hollow. And I don't know if Katie's on this call, but I think you are going to present the tumor size at AQO, and a picture of a cavitary lesion would be lovely. I always find them fascinating to look at. Essentially what happens is you have a solid tumor and the middle of it just sort of dies because there's not enough blood flow as the tumor gets larger and larger. And so you end up with a tumor that looks kind of like a donut.
Yeah, I don't see Katie, or I don't think Katie and Whitney are on today, but we can definitely get that over to them.
Will do. Okay, Odette, if the patient is already in the ICU but decompensating, requiring intubation, multiple unexpected complications, should we code escalation of care since the patient is already in the ICU? Per the training manual, escalation of care does not require the patient to be moved to a new room, but rather is intended to capture a change in status of level of care required per the ADT. So when we say per the ADT, what we're talking about is room status type. And what we were trying to clarify, and what I can go back to the training manual and try to do a better job of clarifying, is that some hospitals have flex rooms. So you can be in a patient status of PCU and you can be in a patient status of ICU, but you can be in the same room because the nurses are trained to perform both types of care. And so what the hospitals do is just change your status without changing your location. So because your patient was in the ICU and stayed in the ICU, there's no change in ADT status. And so you're gonna, you would not capture unexpected escalation of care. They were an ICU patient all the way along. And I should say there's more on this in the training manual about some other sort of one-off scenarios. So if you have questions about what equals unexpected escalation of care outside of Odette's question, please look at the training manual because there's a whole lot more.
Yep.
Michelle had the same question on cavitary lesions. They are solid. Because essentially, so more on cavitary lesions, your CT report is measuring from outside edge to get the total tumor size. In ground glass lesions, when they measure the solid component, they exclude the outside of the tumor because they can capture only the solid part that's in the middle. So I think once you see a couple of these lesions like lined up in slides, hopefully at AQO, it'll make a lot of sense why cavitary lesions are captured as solid. And ground glass or mixed density lesions are, you only measure the solid piece. Shadi, thanks for the code for robotic S2900. Brenda's question. A patient had a robotic assisted left upper lobe wedge resection and inferior pulmonary ligament mediastinal mass node excision. The mass was at the base of the pulmonary ligament wedge. Sorry, I'm trying to get to the, what's the question? There was a pleural base nodule in the left upper lobe, which was sent for section. Both came back as metastatic, poorly differentiated adenocarcinoma. A level 9 lymph node was removed and sent for permanent section. The lymph node was negative. The report doesn't address invasion of visceral pleura or adjacent structures and margins. How would I code analyzed and concomitant procedures? So
if you need it.
What'd you say?
I've got the DCF up if you need it, just FYI.
Thank you. What I'm trying to figure out, I am not sure. So Brenda, I might have to take this one offline because I'm not 100% sure whether it was metastatic, meaning from one lobe of the lung to the other lobe of the lung, or whether we're talking about metastatic adenocarcinoma from somewhere else, which is going to completely change what you want to code. Or maybe if you want to submit a little bit of clarification, I'll come back to your question and go from there. Kim's question, can you explain what the reason is for supplying secondary codes in 1470, such as EGD, bronch, etc.? So presumably 1470 is procedure. The STS is trying to capture all of the procedures performed. so that they have a complete data set, is my understanding. And I'm, many papers get written out of the database. Carol or Leanne, I don't know if you have more context on that, but they're always seeking out valuable data on procedures that patients have had so that they can guide treatment in the future and what's best for patients.
Yep. I don't have anything to add. I don't know if Carol does.
No, I don't.
Dr. Cedar could probably give you like a soliloquy on that one, Kim.
Maybe we should have him. He could AQO. We could ask him and let him provide more information.
Yeah. Michelle, I will get your FAQ back to you today. Sorry about the delay. I haven't seen any more come across from Brenda. So Brenda, if you want to email me some more information, I'll just need to know whether it was metastatic from the lung or metastatic from somewhere else, and then I can give you more detail.
She said she would submit it via the FAQ.
Oh, sweet. Thanks. And then Carol already answered the other question. So I think we are out of questions with 10 minutes to spare. So if anyone has more questions, we have 10 minutes.
I am not seeing anything. Just real quick, if we're waiting to see if any additional questions roll in. Our next upcoming webinars, our monthly webinar is our next monthly one is scheduled for September the 13th at 2:30 Central. Just note that our user group call for September the 27th has been canceled, as that will be right in the middle of AQO. So that user group call for September the 27th will be canceled. It looks like Laura submitted a question here in the meantime. Ruth.
Sure. In sequence 3780 post-op PE, would a non-acute PE be captured? Incidentally noted, non-occlusive left upper lobe, pulmonary embolus. Findings are favored non-acute in etiology. Let me look and see if we've commented on this in the training manual. My guess is probably not, since you're submitting the question, but let me just hop over to 3780.
Oh, I can
See what it says. I know we talked about SVT.
No, we don't have anything.
Laura, let me reach out to Dr. Cedar and see what his thoughts are. I know we're bumping up against the harvest, and I'll get an answer for you before harvest.
Do you want her to submit that to FAQ?
No, that's okay. I got it.
Okay. Okay, you got it. All right, perfect. Thank you. And Julie has a question. Thank you, Laura.
How is pleomorphic carcinoma coded for sequence 2070? Lung cancer histology. I believe there are other, but I will confirm with my notes and or Dr. Cedar if not available.
All right. And Julie had her hand up. Julie, you should be, if you could unmute, there you go.
Yeah, I was just saying that question was submitted quite some time ago to the FAQ on the website.
Okay. Oh, perfect.
I'll
Thank
check.
you.
Maybe I've got notes.
Thank you.
Yeah, no problem.
All right. Perfect. All right. I am not seeing any additional questions. All right, perfect. All right. In the meantime, again, just rather quickly, if as I know, harvest is quickly approaching and you guys are submitting those files. If you have any questions that come up while you're submitting that harvest, if you have any questions related to the IQVIA platform or data quality reports, anything like that, please submit those questions to stsdb_helpdesk@sts.org. Again, don't send them to me directly, as I do not have access to many of the site specific reports. So again, just please submit those questions to stsdb_helpdesk.org. Sorry, there's a question in the chat, Ruth.
Yes, it looks like somebody wants to know, well, do you want me to come back to it?
Yeah.
Or
Yeah, sure, go ahead.
what was the original question when you said S2900 for robotic? I missed the question. There was a previous question about how to capture robotic cases, and I said capture thoracoscopic, and then you're going to code the procedure for robotic. And Shabi kindly pointed out that the correct procedure is S2900 robotic when you're coding the robotic procedure. And then there's also a checkbox for robotic that you will check if you have a robotic procedure.
Great. You're welcome. All right. Well, again, harvest close is quickly approaching. One last plea, please, please, please do not wait until the very last day. Get down to that last hour to submit your file. Inevitably, something will go wrong. So again, I just please do encourage you to submit those files prior to the harvest close deadline of the 8th. If you have any questions, please reach out. We're happy to help. If you're not sure where to send your questions, reach out to me directly. I can point you to the right direction. With that being said, Ruth, thank you so much for answering all those questions today. Greatly appreciated. Emily, thank you for the AQO update. And Carol, thank you for your support as usual. Couldn't do this without you. So thank you so much, everybody, for joining today. I hope you guys have a great rest of your week. If you have any questions, again, please don't hesitate to reach out. We are here to help you in any way possible. So with that, I hope you guys have a great rest of your week. And again, we're looking forward to AQO, and we'll see you guys soon. Thanks, everyone.